So I'm going to talk to you today about neuro-ophthalmology. This is again a very important topic and quite complex in its own way. So I'm going to try and make it simple. I'm going to cover only a few common conditions relevant to your practice, also relevant to the examination, as some of these topics will be definitely asked of you in both the theory, and you could get this in the practical. So today we're going to talk about stroke, a slightly longer presentation because there's lots to cover, but I'll try and make it as simple as possible for you. Stroke is, by the way, a separate speciality in the UK, which is apart from neurology, though there's a considerable amount of overlap, but unlike most countries, stroke is treated by stroke physicians. So it's a medical condition in which, due to lack of blood supply, there's a problem in the brain and causing cell death, and depending on the area of the brain affected, it manifests with certain signs and symptoms. There are two major types of stroke. One is the ischemic strokes due to lack of blood supply, and a hemorrhagic stroke due to a bleed. But 85 to 87% of strokes are ischemic, the rest are hemorrhagic. Sometimes there can be a bleeding within an ischemic stroke, particularly if it is a big lesion, and this is called a hemorrhagic transformation of stroke. Now, the WHO defines stroke as a neurological deficit of cerebrovascular cause that persists beyond 24 hours. Or is interrupted with death within 24 hours. The 24-hour limit divides stroke from transient ischemic attacks, in which a relative syndrome or stroke symptoms develop but resolve almost completely within 4 hours. Stroke is the second most leading cause of death and is highest in developing countries, with ischemic stroke being the most common type of stroke. It's also the leading cause of a second leading cause of death worldwide. Now, I've already mentioned that about 85 to 87% of strokes are ischemic, and their prevalence has increased substantially between 1990 and 2016, attributed to various points as indicated. So what is the pathophysiology behind stroke? Now, ischemic occlusion generates thrombotic and embolic conditions within the brain. In thrombosis, the blood flow is affected by narrowing of blood vessels. Due to atherosclerosis, the blood vessel wall is already affected, and there's a buildup of plaque, which ultimately builds to a critical point, and this will lead to constriction of the vessel, forming clots and causing a thrombotic stroke. An embolic stroke, there's decreased blood flow to the brain due to an embolism, which may arise from another artery or from the heart itself, again causing reduction of blood flow. This leads to cell death, necrosis. There's disruption of the plasma membrane. The cellular organelles are swollen, and there's loss of neuronal function as the terminal result. There's of course inflammation, energy failure, loss of homeostasis, acidosis, and increased intracellular calcium levels, excitotoxicity, free radical damage, all of which contribute to causing the pathophysiology of stroke. Hemorrhagic strokes are generally 10 to 15% of strokes, but have a higher mortality rate, as this tends to be a catastrophic event, and there is essentially rupture of blood vessels, and this can lead to cell death. Once again, the main reasons for intracerebral bleeds are hypertension, disrupted vasculature, excessive use of anticoagulants and thrombolytic agents. In subarachnoid hemorrhage, blood accumulates in the subarachnoid space, and most of these are due to intracerebral aneurysms, though traumatic and idiopathic hemorrhage can occur. Now, This is a classification that everyone in the UK is familiar with. John Bamford proposed this with a working group in Oxford, and strokes are basically divided into four basic categories. The first is lacunar infarcts, or LACI. Any of these can be either a pure motor stroke, a pure sensory stroke, a sensory-motor stroke, ataxic hemiparesis. Usually they do not have high cortical function loss and usually subcortical, and most of these involve either the cortical, the pontine vessels, the lenticrostriate arteries, the pontine perforators, and constitute about 25% stroke. The second in this is the total anterior circulation infarct, or TACI. Basically, they have high cerebral dysfunction, aphasia, 𝒃𝒂𝒄𝒂𝒅𝒆𝒚, with usually visual field defects. There's one-sided motor or sensory deficits, and it usually is due to a large stroke involving the middle cerebral or the anterior cerebral arteries, and the anterior circulation infarcts constitute about 20% of strokes. The third in this category is the partial anterior circulation infarcts, PACI, and basically they have some components overlapping with the anterior circulation infarcts, but there's a motor sensory deficit, and they have also visual field defect, ipsilateral motor and sensory deficits, and these are usually smaller cortical strokes, again involving the MCA or the ACA territory. And then finally you have the posterior circulation infarcts, which basically can cause, if you remember my talk on localization, cranial nerve deficits with contralateral motor or sensory deficits. The cranial nerves generally are easy to remember. The third and fourth cranial nerve are in the midbrain, the sixth and seventh cranial nerve in the pons, and the remainder of the nerves are in the medulla. The fifth nerve tends to run a long course through these areas, and depending on where the lesion is located, you can have a combination or constellation of cranial nerve involvement with the long tracts, that's the sensory and motor tracts. There is a disorder of conjugate eye movement, which is generally coordinated in the brainstem. There is cerebellar dysfunction of the cerebellum is involved, and there is a visual field defect. Usually the arteries involved are the vertebral or the basilar artery or the posterior cerebral artery, and this constitutes about 25% of stroke. Now, I already mentioned intracerebral bleeds, which constitute about 10 to 15% of all strokes. Some of the risk factors for this are hypertension, age. They're generally more common after 55, and elderly people have a condition called amyloid angiopathy, which weakens the vessel walls and can cause bleeds. Again, they're more common in men, and more common in African Americans and Asians. There's previous history of stroke increased the risk quite considerably, and of course the remainders, as mentioned, alcohol use, street drugs, use of anticoagulation, all contribute to the risk of intracerebral. Intracerebral hemorrhage is characterized by smooth progressive onset over minutes. Usually it's a very catastrophic onset preceded by a headache and sudden loss of consciousness. They can have seizures. The headache is usually accompanied by nausea and vomiting, and presents with focal neurological deficits. Generally, we investigate intracerebral bleeds or any form of bleeds with a CT scan. A CT scan is quick and easily available, and will pick up a bleed quite quickly and comfortably. In fact, is the preferred investigation modality of choice. There is patients who will deteriorate with a bleed which might be minimal in the beginning due to rebleeding, also due to swelling or cerebral edema. They can develop hydrocephalus as due to blood products, the circulation of CSF can be blocked, and of course due to seizure. Treatment focuses on stopping the bleeding, removing the clot, relieving pressure on the brain. Treatment is tailored to the patient and depends on individual cases. If it's a small bleed, sometimes it's best left alone with control of blood pressure, and and blood products can resolve over a period of time. Now, if patients have minimal symptoms, as mentioned, or minimal chance of on the other hand, a minimal chance of a favorable outcome, if there's a large hemorrhage and the GCS is very low, which is the Glasgow Coma scale, then advanced stage or bleeding disorders, then we would probably not intervene. Also, location of deep bleeds, as in the basal ganglia region, would probably respond better to conservative treatment. Basically, patient is given some clotting factors. If the patient was on blood thinners, and blood thinners immediately stop, blood pressure is controlled, and we monitor the intracerebral pressure to ensure that the brain is perfused and yet no bleeding is controlled. Now, for surgical treatment, generally we offer it to younger patients with a hemorrhage in a favorable location that is easily amenable to the surgeons, and in where there's less risk of rebleeding, edema, or necrosis. And it can either involve a craniotomy, where you remove a part of the skull and allow the brain to swell and then replace it back at a subsequent date, or a stereotactic clot aspiration via a catheter, which essentially needs the use of neuronavigation, and this was able to remove the. Now, a word about subarachnoid hemorrhage. It usually presents with a thunderclap headache, and it's important to remember that the thunderclap headache usually has a precipitous onset, and the headache builds up in seconds to minutes rather than hours to days. The symptoms include a severe headache, vomiting. They can have decreased level of consciousness, fever. Sometimes they can have seizures as well. Neck stiffness and neck pain are also relatively common, and usually if it's a small bleed, it will resolve on its own. It can occur as a result of head injury. Sometimes it can be spontaneous or from a ruptured cerebral aneurysm. Now, background risks, which even in a setting of an aneurysm can increase the risk for bleeding, include uncontrolled blood pressure, smoking, family history of the same alcoholism or cocaine use. Now, generally, as these patients present, it's extremely important to investigate them accurately and sensibly. Initially, a CT scan is recommended, and should be done as early as possible. Thereafter, if the CT scan is normal and still the condition is suspected, we do take the patient up for a lumbar puncture. 3 samples of CSF are collected. If the elevated number of red cells is equal in all the bottles, it indicates a bleed. On the other hand, if the third tube shows a decreased number of red cells, it indicates that it's probably a traumatic tap. It's also examined for xanthochromia by spectrophotometry, in which the yellow appearance of the centrifuged fluid is tested, and essentially this indicates a bleed. Interval of at least 12 hours between the onset of headache and lumbar puncture is required, as it takes quite a while for the hemoglobin from the red cells to be metabolized into bilirubin. Therefore, timing is extremely important. Likewise, these patients are taken up for a CT angiogram, but it's usually done about 6 weeks later, as if you do it immediately, if there's vasospasm, you may miss picking up an aneurysm. Now, neurosurgery is generally offered to patients depending on the site, location, and size of the aneurysms. They can be clipped or coiled. This is a decision taken by the neurosurgeons. Medication-wise, they are offered labetalol, especially if they have got uncontrolled blood pressure. And to lower the blood pressure till repair can occur, a calcium channel blocker called nimodipine is offered to prevent vasospasm. and seizure medication is offered if patients have had seizures. Now, the mortality can be fairly high, and so this is treated as an emergency. Any thunderclap headache presenting to A&E is treated as a subarachnoid hemorrhage till proven otherwise. As regards investigations of an ischemic stroke, usually a CT scan is offered. It may be important to understand that initial CTs can be negative for the first 24 to 48 hours, and sometimes you may need to repeat a CT to get an accurate picture. Subsequently, these patients, if they're in a hospital setting, do undergo an MRI with diffusion weighted imaging, which generally helps to pick up early strokes. Vascular imaging may be required in some cases. Dopplers are done to check the neck vessels to see if there's any atherosclerosis or critical narrowing, as these patients may need to be sent to a vascular surgeon to prevent further strokes. A full cardiac workup, including echocardiogram, sometimes an arch aortogram, as well as ECG monitoring for a prolonged period of time to rule out intermittent atrial fibrillation, etc., needs to be carried out. And of course, bloods are done to basically look for secondary risk factors vascular which are associated with cerebral vascular disease, especially diabetes, bleeding disorders, etc. And thereafter, patient is offered treatment as appropriate. Now, a few words about epidemiology and risk factors. The risk of stroke increases with age and doubles after the age of 55 years for both men and women. The risk is increased further when an individual has an underlying medical condition such as heart disease, dyslipidemia, or hypertension, and some patients will have a previous history of TIA. The risk factors can be divided into modifiable and non-modifiable risk factors. Non-modifiable risk factors include age, sex, ethnicity, previous TIA, and some hereditary characteristics, whereas modified risk factors are basically hypertension, diabetes, lack of exercise, alcohol, drug use, dyslipidemia, etc. Stroke prevention involves modifying the risk factors in those that can be modified, and management, of course, depends on treating the pathophysiology. There are no simple means of treating or preventing strokes as yet. If patients present within the time window, they're offered intravenous thrombolytics if they fulfill the criteria and all risk factors are excluded. And this would be important for you all to read this from a textbook, as some of this would have to be committed to memory. However, it may be emphasized that all flowcharts for such procedures is available in every stroke unit, and so can be referred to in an emergency setting. Now, basically, the efficacy of thrombolytic therapy depends on the age of the clot, the specificity of the thrombolytic agent for fibrin, and the presence of neutralizing antibodies. Basically, the drugs used in intravenous thrombolysis aim to promote fibrinolysin formation, which leads to dissolution of the clot, blocking the cerebral vessels. The most effective is alteplase, which is RTPA, which was developed by the National Institute of Neurological Disorders and Stroke in the US, and it reduces the clot diameter and improves reperfusion if used within 3 hours of stroke. And various studies have confirmed its efficacy. Intraarterial thrombolysis is another approach which is most effective in the first 6 hours of onset of an occlusion, especially critical occlusions, but requires a team of experienced clinicians and angiographic techniques and the availability of a lab with a team on call to be able to offer this to patients. Blood pressure is to be controlled as it's a major risk factor for stroke. There are many reasons for high blood pressure in stroke, including a history of hypertension, acute neuroendocrine stimulation, increase intracranial pressure, stress related to hospital, and of course episodes. It's important to control the blood sugars and maintain the blood sugars within range, and having uncontrolled hyperglycemia, post-stroke complications. Patients are started on antiplatelets, usually dual antiplatelets in the beginning with clopidogrel and disprin, and subsequently a single antiplatelet. And various antiplatelets are available, including ticagrelor. Subsequently, patients are sent for rehabilitation, and they're managed under a rehabilitation medicine consultant. The aim is, of course, to increase the functional independence of people affected by stroke. They have specific strategies, including physiotherapy, and teaching them about various aids that can help the patient. Stroke rehabilitation involves lots of aspects, including occupational therapy, speech and language, cognitive therapy, and basically it tries to restore patients as close as possible to their existing activities of daily living and quality of